Good afternoon. I'm David Luberoff, Deputy Director of the Joint Center for Housing Studies, and it's my pleasure to welcome you to today's talk by Samara Scheckler, examining what happens to spending on health when older adults pay off their mortgages. Before I turn things over to Samara, I have a few announcements and a couple of housekeeping items. First, on October 21st, which is next Thursday at noon, the center, along with the Rappaport Center for Law and Public Policy at Boston College and BC's Black Law Students Association, is sponsoring a panel discussion about zoning and equity with Sarah Bronin, a professor of planning and law at Cornell, Harley Etienne, an associate professor of urban planning at the University of Michigan, Boston City Councilor Lydia Edwards. Conversation will be moderated by Amy Dane, a Boston-based consultant who many of us know for the great work she's done on local zoning in this region. Second, the Housing Research Seminar will continue on Friday, October 29th at 12:15 p.m. when Sophia Wedin, a Center Research Associate, will present findings from a forthcoming center paper examining how renters have responded to financial stress in the pandemic. She's writing that paper with our colleagues Whitney Ergood-Obricki, Chris Herbert, and Alex Herman. Third, I want to let anyone who's watching who is a GSD student writing a thesis or knows a GSD student writing a thesis, and any Kennedy School students writing PAEs, that the center is now accepting applications for grants that can help offset any expenses associated with your thesis work, such as travel you might be planning to do during the winter break. Those applications are due by Tuesday, October 26th. You can find more information about the events, the grants, and many other things about the Joint Center on our website, www.jchs.harvard.edu. A couple of things to note about today's session. First, closed captioning is available from the menu on your screen, if that is helpful for you. Second, you can use Zoom's Q&A function to ask questions. We'll try to get to as many of those as we can, but I do apologize in advance if we don't get to yours. In some cases, we'll also answer them online. And finally, Samara's slide deck and video of today's talk will both be posted on the previous events portion of the center's website. That'll probably happen by early next week. Now, to today's talk. Samara Scheckler, our speaker, is a Joint Center postdoctoral research fellow. She's working on a variety of projects related to community-based aging with a particular focus on how we can maximize health, independence, and quality of life for people with a range of abilities, needs, and resources. She's discussing a new paper that she wrote with our colleagues Jen Molinsky and Chris Herbert, as well as Kacie Dragan, a doctoral student in health policy at Harvard. And by the way, when I say new, I really mean new. The paper was posted earlier today on the website of the University of Wisconsin's Center for Financial Security, which administered the grant from the US Social Security Administration that funded this work. Congratulations. Samara will talk for about 30 minutes. We'll take questions for about another 30 minutes, and then we will wrap up no later than 2:15 p.m. Samara, welcome. It's all yours.
Thanks so much, David. Get my slides up. All right. So before we get started, we should begin with our disclaimer. I'll emphasize that this research was funded through the grant that David just spoke of from the Social Security Administration. Any opinions or errors associated with this research belong to the researchers alone and don't represent any federal agency. So let's begin to motivate this work by exploring why we might care about older adult housing costs. Housing takes a big bite out of the older adult, out of the household budget in general. We consider a household burdened by their housing cost if the costs consume more than 30% of the household income. Housing costs include rent or mortgage, utilities, taxes. They represent the largest budget item for most families. They can take precedence over other important expenditures. As Matthew Desmond wrote in his exploration of very low income households, the rent eats first. So even while budgets are fungible, it can be useful to describe the economic circumstances of a household according to their ability to pay their housing costs. Homeowners who have a mortgage are more than twice as likely to experience housing cost burden as homeowners whose mortgage has been paid off. This brings us to consider older homeowners whose mortgage debt trends we'll discuss on the next slide But 4 out of 10 older mortgage holders experienced housing cost burdens in 2017 as compared to just 16% of older owners whose mortgage had already been paid off. So overall, higher mortgage debt has been associated with higher housing costs and more financial insecurity. Trends show older adults have been carrying more housing debt longer. The share of older adults with a mortgage has doubled over a quarter century, and the amount of debt they're carrying relative to the value of their homes has tripled. On its face, it really isn't clear how much we should worry about this rising late life debt trend. It might be that older homeowners are spending down their housing asset to increase their quality of life and health. It might also be that the increased debt load is suggesting greater strain and limiting their opportunities for healthy community-based aging. These mortgage and housing cost trends undergird the research question we'll discuss today, so kind of keep them in the back of your mind. In this project, we specifically examined the relationship between housing payments and health expenditures. Out-of-pocket healthcare is a large proportion of the budget for older adult households, so we worry about healthcare rationing when households can't afford both their housing costs and their healthcare costs. Living with very low income is associated with cost-related medical non-adherence. In fact, we've seen moderately cost-burdened households spending almost 20% less on out-of-pocket healthcare than similar income households who live in housing that's more affordable to them. Medication rationing is one way that households avoid medical care that they can't afford. Between 10 and 15% of all older adult Medicare recipients and almost a third of disabled beneficiaries have rationed medication that was too expensive for them. Rationing could look like unfilled prescriptions, maybe pill splitting or skipped doses. Medication rationing is concerning because it can reduce the effectiveness of the drugs and impact the patient's health. Patients report feeling worse when they skip their medication, and their self-rated health drops about 10 points. Patients with certain conditions like cardiovascular disease have been observed getting sicker when they don't take their medication as prescribed. Cost-related non-adherence to medication is also expensive. When considering adults with diabetes, cost-related non-adherence to medication has been estimated to cost the US economy up to $100 billion a year. Perhaps most alarmingly, healthcare rationing has been associated with increased risk of nursing home admission, especially among Medicaid recipients, and an increase in all-cause mortality. So to finish this discussion motivating our work, we should consider the potential magnitude of the problem presented by these trade-offs between housing costs and healthcare. Many adults incur large out-of-pocket healthcare costs. These include deductibles, cost share, uncovered services, and premiums. So 1 out of 4 Medicare recipients recently reported spending at least 20% of their entire income on out-of-pocket health costs. Medicaid and Medigap plans can reduce these out-of-pocket burdens, but many low-income older adults don't have access to that coverage. So in this research, we focus on the end of mortgage payment period with the idea that finishing a mortgage lowers housing costs and frees up money to pay for other things. We expect to find pent-up demand for healthcare, specifically out-of-pocket pharmaceutical spending during the higher housing cost period. And we anticipate that when the mortgage is paid off and the housing costs fall, we'll observe increased pharmaceutical spending in households that had been making trade-offs between housing costs and their health spending. To do this work, we chose to use the Health and Retirement Study, which offers panel data for middle-aged and older adults. Data was gathered in the study every 2 years, beginning in the early 90s. In general, the HRS produces good quality measures of out-of-pocket spending as compared with other health-specific data such as the MEPS or the MCBS. We used a difference in differences model to compare health spending changes between households in which a mortgage ended and households that had no change in mortgage status. As our indicator of outstanding mortgage debt, we used an HRS variable that asks about the mortgage payments on the primary residence. If the household reported any amount in this field, The household was coded as actively paying a mortgage during that wave. We modeled a 4-wave end of mortgage period. Our treatment group was made up of households that had 2 waves with a mortgage payment, followed by 2 waves without a mortgage payment. And then we compare this to a control group of households with steady payments, since either they were paying over 4 waves or they never paid a mortgage over a 4-wave period. So to be included, 2 types of households were actually never met our inclusion criteria, this 4-wave criteria, because they didn't remain intact through a treatment period. So these included households that experienced a divorce or new marriage and households that dropped out of the data due to death. We also excluded households that moved during the payoff wave or the wave prior, since access to that liquidated housing asset from a home sale could confound our results. To be included in our control group, households could not be in the treatment group. And then we applied the 4-wave of payment or no payment criteria. If a household met these criteria for more than 4 waves, we selected 4 consecutive waves at random. We chose to use out-of-pocket pharmaceutical spending as our measure of health spending for a few key reasons. First, prescription medicine represents a large portion of out-of-pocket spending, and growth in pharmaceutical spending is driven by out-of-pocket costs. Second, unlike some out-of-pocket health costs, which narrowly apply to a handful of conditions, prescription drugs are drivers of out-of-pocket expense for many common conditions, including cardiovascular disease, diabetes, and hypertension. Finally, while many out-of-pocket health costs are concentrated among a small set of high-spending patients, out-of-pocket pharmaceutical cost spending is fairly evenly distributed across the population. Only about half of out-of-pocket pharmaceutical spending is attributed to the top 10% of health spenders. It turns out that premium costs are the only out-of-pocket expense that's less concentrated than pharmaceuticals. To model out-of-pocket medication costs, we used a question that HRS asks, on average, how much a respondent pays each month for prescriptions. We collected this response to the household level and divided it in half for married couples. So for our dependent variable, we had a household spending rate on out-of-pocket pharmaceuticals per person per month, again, focusing on the individual and their spouse if they're married. We modeled other expected demographic variables. These variables were all assessed at the household level, and this requires some special treatment for a couple of them. When considering age for married households, we randomly used the age for either the older or the younger spouse. The race or ethnicity variable was operationalized as an indicator for a potential health disparity that would be associated with racial or ethnic identity. So we created a binary variable that would flag any household in which either the respondent or the spouse identified as Black or Hispanic. Similarly, flags were used to associate households with one of 8 mutually exclusive combinations of insurance at the household level. You can see them listed here on the slide. Income was included in 2 ways, both as a continuous variable and also as a flag for low-income households. And all of these measures were converted to 2016 dollars. Assets were also included, with one variable that quantified liquid assets and a second that captured illiquid assets. This is important because older adults do tap equity to pay for healthcare and to buffer against food insecurity and other consequences. For instance, borrowing against home equity has been found to reduce prescription drug non-adherence in past research. Total household members were counted, even though payment data was only assessed for the single person or the married couple. But if there were other people in the household, they were captured in this variable. Finally, health was incorporated both as an indicator for a household member who was within 5 years of death at the 3rd wave, and also at the count as a count of chronic conditions per person. So looking at our results, in the first column of the table, you can see that 156 households qualified for treatment, but were excluded because the household relocated. Some demographics are also reported for these movers, and you can see in the column to the far right that there were no statistically significant differences in these demographics. between households that were excluded due to relocation, and those were included in the treatment group, they essentially are the same. There were 1,035 households included in the treatment group and 4,110 included as controls for the main analysis. But you can see that there were some significant differences between the demographics of our treatment and control groups. Households in the treatment group were younger, wealthier, and they were more likely to be married. As we start to look at results, I'll take a moment to orient you to the interpretation for this analysis. So the analysis is designed to show us the change in pharmaceutical spending after treatment, which is the making of the last mortgage payment. In the graph on the left, you see average out-of-pocket drug spending at each wave for the treatment group in the dotted line, and the average out-of-pocket spending for the control group in the solid line. I'll remind you that wave 2 is the last wave in which a treatment household reported a mortgage payment, and wave 3 is the first wave in which a treatment household reported no mortgage payment. The graph on the right shows our treatment effect, or the second difference for this analysis. To plot these points, we calculated the first difference, which measures the change in spending between wave 2, the last wave in which the household made a mortgage payment each month, and any other wave. So for instance, the first difference at wave 4 finds the difference in spending between waves 4 and 2 for the treatment group, and then separately finds the difference in spending between waves 4 and 2 for the control group. The second difference, these are the findings plotted here on the graph, compares the size of the first difference between the treatment and control group at each wave. So the point on the graph, the last point on the graph, gives us the size of the first difference between the treatment group and the control group at wave 4. We find in this case that at wave 4, the treatment group spent an average of $9 more on out-of-pocket pharmaceuticals than the control group spent. This is a 25% increase in spending from wave 2 and was significant. You might notice that there is no treatment effect until wave 4. Remember that each wave represents a survey looking back on 2 previous years. We know that sometime in wave 3, before the survey interview, the treatment household made their last mortgage payment, but we don't know if this happened at the beginning, in the middle, or near the end of the wave. So some households, that wave 3 budget is going to look more like the wave 2 budget, with a mortgage payment intact most of the wave. And for other households, the wave 3 spending is going to look more like wave 4, in which there was never a mortgage payment for the wave. So wave 4, in the sense, offers a cleaner and sharper comparison between the treatment and control groups, and is the clearest representation of our treatment effect. To refine these results and examine the implications of age, we conducted a triple difference. This basically means we ran separate analyses for each age group so we could compare the differences in our findings by group. The under 65 group were households in which both respondent and spouse were under age 65 across all 4 waves. And the 65 and older group were households in which the respondent and spouse were both at least 65 across all 4 waves. If either respondent or spouse crossed this age threshold in the observation period, the household was tossed out of the analysis. We found that the out-of-pocket pharmaceutical spending was most sensitive to the end of mortgage period for the homeowners between ages 50 and 64. You can see these younger households in the treatment group increased their out-of-pocket pharmaceutical spending by around $20 each month in wave 4 as compared to the control group. This is a 50% increase in their spending. On the other hand, there was no treatment effect. There was no effect for homeowners 65 and older, meaning there was no change in their spending. It was pretty similar between treatment and control groups for these older households. So let's do a couple slides to see if we believe these findings. One underlying assumption of a difference in difference analysis is that the pharmaceutical spending would have to be the same between treatment and control groups, but for the mortgage ending. To more carefully examine this assumption and see if it holds up, we add an additional wave of pre-trend to explore the parallelness of trends prior to the treatment. You can see this additional data called wave 0 on these graphs. Even though the treatment period is actually, it's an ambiguous space between waves 2 and 3, we drew a red line halfway down between the 2 waves to help your eye find where on average the treatment, that last mortgage payment, might be expected to occur. For both graphs, spending trends prior to the treatment tracked pretty similarly between the treatment and control groups, but in the under 65 graph on the left, the trend lines do appear to diverge after the treatment line. In the over 65 graph, where we observe no effect, we don't see any clear divergence in spending after wave 3. So we feel pretty good about the similarity of trends before treatment. We might also worry about the composition of our comparison group. Remember that the control group is made up of two types of households, those that always had a mortgage and households that never had a mortgage. The logic of selecting the two types is that they both had stable mortgage costs, stable housing costs, which should result in a steady relationship between housing costs and pharmaceutical spending during the observation period. But the two types of control groups are demographically different from each other. So we ran the analysis on each group separately to ensure that neither of these types of households was singularly driving the effect. These graphs show the difference in treatment effect when comparing mortgage holders who were paying through all 4 waves and homeowners whose mortgage was paid off for all 4 waves. You can see the effect was smaller. There was less difference in the graph on the left when homeowners had no mortgage payment for 4 waves. The size of the effect in the graph on the right represented homeowners with 4 waves of payment. The effect was a little bigger, but both control groups did demonstrate significant effects at wave 4, and the size of the effects are pretty similar between household types. So we feel comfortable with our decision to combine these two types of homeowners into a single comparison group. You might also recall that we randomly selected the 4 waves to include in the comparison group when households met criteria for more than 4 waves. So we ran our analysis using 20 different random draws and found very similar results across trials. So we feel confident that we weren't selecting outlier households when we randomly selected these 4 wave periods for our control group. Remember also that our treatment and control groups did have some significant differences on some demographic measures. So to further test our assumption that the treatment and control groups were similar across demographics that were meaningful to this analysis, we ran a coarse and exact match algorithm on the sample. So this algorithm matched treated and control observations at the household level based on a set of demographics that were assessed in wave 1. These included income, age, marital status, HRS cohort membership, wave of payoff, as well as number of chronic conditions. Differences found using this method were significant still and were very similar to our difference in difference analysis. The magnitude was somewhat smaller. We found a $12 difference in spending, monthly spending for the under 65-year-olds as compared to control. But again, the difference itself was significant, and we feel like it's in the ballpark. Finally, concerns might arise about reverse causation, that these results that we're reporting might ultimately be driven by changes in health. So for our first pass at this problem, we present these sample descriptives of the treatment group and point out that there was no jump in either new health diagnoses or new ADL support needs that occurred during the treatment wave, between waves 2 and 3. To further explore the potential role of health to this story, we created an indicator for any household that had a new health diagnosis between waves 2 and 3. And we ran a triple difference where we divided the sample according to households that had a change in health status versus households that had no change. We ran the same mortgage and spending analysis on each health sample separately, and we didn't find any significant difference in treatment effects between the households with stable health over time and households that experienced a new diagnosis or reported a new diagnosis. This adds to our evidence that health changes weren't driving the findings that we're reporting today. So let's think about key takeaways. Our research suggests that there are spillover effects between housing costs and prescription drug use, and that pharmaceutical spending of homeowners between the ages of 50 and 64 is particularly sensitive to their housing costs. When households in this age range finished paying off their mortgages, they spent an average of $20 more each month on prescription drugs, which is a 50% increase in their medication spending. This could easily account for an additional monthly prescription fill. Research suggests that there are serious health consequences of pharmaceutical non-adherence. It's hard for patients to assess the value of a drug, especially when the therapeutic effects might be delayed or difficult to observe or experience. As a result, patients who choose to skip medications to save money aren't necessarily strategic about minimizing the consequences to their health. Faced with inadequate funds, some patients choose not to take drugs that would have provided meaningful health benefits. So in sum, pharmaceutical access matters. When Medicare Part D expanded drug coverage to older adults, one study estimated that older adult mortality dropped by more than 2% each year that older adults had access to that additional coverage. On the other hand, there were no changes in health spending for households 65 and older who paid off their mortgage. But older adults tend to have lower incomes and worse health. We should see a bigger jump in health consumption when housing gets cheaper for these older adults, unless something's happening around age 65 to relieve budgetary pressures and make older adult health spending less sensitive to their housing costs. So there are policies that kick in at 65 that provide income and healthcare subsidies, right? Beginning at 65, Medicare reduces premium costs for some households, expands access to insurance for households, closes coverage gaps, and reduces dependence on employer or ACA state exchanges. There's a cost to receive prescription drug coverage through Medicare, but there are some resources to reduce that cost. The Social Security Administration's Extra Help Program, also known as the Low Income Subsidy, assists low-income houses to purchase Medicare Part D prescription drug plans. So with the infusion of public subsidies beginning around age 65, homeowners appear to be able to simultaneously afford the cost of both their medication and their housing, and their health spending is no longer so sensitive to their housing costs. So thinking about implications, in this analysis, we weren't able to separately assess the impacts of an income, of insurance, of race or ethnicity. We couldn't separately look at geography as we were thinking about the relationship between housing and health spending. We really hope that future work will be able to tease out what precisely is going on at age 65 to reduce pharmaceutical rationing, and we'll identify specific programs. We hope to identify specific programs and policies that limit these trade-offs. Subsidies could target this need by lowering housing costs, by increasing income for older adults, or by reducing healthcare costs. So it would be really valuable to better understand whether one of these mechanisms is more efficient than others in helping households simultaneously manage their health and housing needs. So I appreciate your thoughtful attention today, and I look forward to the conversation that we can have now.
Samara, thank you. There's a lot to chew on here. Let me just start. Help me think about. I guess I don't know that you have any data on the size of the mortgage payment. The increase in spending on drugs you said is $20 a month, and I'm trying to figure out whether I should think that as a big figure or a little figure or somewhere in between.
Yeah, that's a really good question, and I think there are a couple different ways to approach it, right? I think if we want to consider health impacts, $20 can mean a prescription fill, right? $20 can mean a copay to continue taking a drug that may be life-saving to me. We also need to remember that $20 is an average, right? There are some households that aren't making any changes in their spending. So that means that there's some houses that are suddenly spending quite a bit more each month once their housing costs are relieved. So they may be able to take those more expensive medications, or maybe they're switching from generic to a medication that was specifically prescribed by their doctor for various reasons. So in that sense, even though it's like a small dollar amount, the impact on health of these older adults, it could be very large.
Do you have again, I don't know what the data allow. Do you have a sense as to how wide that distribution looks in terms of the spending?
We don't. I don't. And it's an interesting question, right? It's hard the way we did our analysis to understand like which household. So if you think about it, everybody in our data is getting older. Everybody in our data, as they get older, are likely to get new health conditions and to spend a little bit more on medications. So we're trying to identify the houses that are spending more than they would have otherwise spent more, right? So it's that change effect that makes it harder to maybe assess that trend in dollar amounts.
So I think the last point you made is sort of what the point you were making in that the last slide before you moved to discussion, that there doesn't seem to be anything else odd going on that would be driving spending. But the takeaway here is, because I guess I found myself thinking the mortgage, the reduction in mortgage payments got to be a lot bigger than $20. One would think. So at some level, where else is the money going? And again, how significant is this? Since if you
I think that's an interesting question, David. And there is some literature that thinks about this end of mortgage payment period. A lot of the literature that has done this is in the economics field and has conducted internationally, and they look, for example, at increases in durable good purchases or increases in saving, or, just basically people have extra money all of a sudden and how are they using it? There's not a ton of research that has looked at that end of mortgage payment period here in the US, which I think is why there's not a lot that's thought carefully about health spending, because in a lot of other countries, health spending isn't so sensitive to income, right? We have a system that ties our healthcare costs very, very closely to our ability to pay. I'm afraid I lost my train of thought. Remind me the beginning of their question, because
it was again that the reduction associated with having paid off the mortgage is almost surely magnitudes greater than the increase in the spending.
Yep. So the only other point I wanted to make remember, we're looking very specifically at pharmaceutical spending because we anticipated that pharmaceutical spending is important. We anticipated that it would be sensitive and easier to observe. That doesn't mean that there's not money going into other things, right? This study could be conducted maybe looking at people's utility bill arrears. Maybe it could be looking at, maybe people are putting off elective surgeries. Maybe people, there are like many other analyses that could be done. We chose to specifically look at pharmaceuticals because it's easier to capture in those small dollar amounts, right? There's just going to be more change. But you're absolutely right that there's potentially a lot of other action going on in these households when they all of a sudden have some money freed up.
And I don't know whether A, you can get this from the data, and B, if you did, do you know anything about the way people go about paying off their mortgages? I mean, do we think it was just, I paid it off and, like in the old days, I'd have the ceremony to burn the note, or is there something that we think there's a point where people all of a sudden pay off the mortgage? Does the data tell you anything about that?
I love that you asked this question. We spent maybe the first 3 months of our research process trying to answer that question and trying to figure out what these end of mortgage payment periods look like. And we're going to write up that work also. There were distinct trends. So some households did just what you said, right? They paid off a little bit a month as expected, and then the mortgage slowly disappeared. But a lot of households, like a significant number of households, ended payments in this huge cliff. So they might have $80,000, $50,000 left in their mortgage, but at least by their report in the data, and then their mortgage was gone in the next observation period. So some of the tasks that we tried to do were to figure out how, right. What kind of systematic explanations might there be for that behavior? It wasn't necessarily explained by people moving or by people retiring, or people weren't, in the HRS, there's so much information about people's assets. They weren't necessarily cashing out in one area to pay off their housing. So there did seem to be some proportion of householders that experienced some life change and decided to use, cash on hand, basically to get out of their mortgage for some reason. And again, this is something that we need to pull out a shovel and dig into. We also want to kind of understand. We think we maybe should just understand the data a little bit better. Make sure that the reporting, that there aren't reporting effects that we're kind of glossing over or missing.
It's why I found myself just thinking about, I liked your list of, what would change. And the only other one that came quickly to my mind is the cohort you're dealing with also has a lot of folks who may finally not be paying college tuition.
Good point.
And that I noticed that changed cash flow pretty significantly. Question that comes from the Q&A, and I'm going to read this because I could never summarize it correctly. It says, starts by saying, thank you for a great talk. And then it says, the very first figure you presented depicting linear predictions, you may want to pull this back up, not broken down by 65 plus decomposition, seems to suggest the effect you observed was driven more by a wave 4 drop in control group spending than a wave 4 increase in treatment group spending. Is that a correct interpretation of the initial figure? If so, could you elaborate on why you think this is the case? Asset depletion over time, something else?
All right. So I'm afraid doing two things at once has never been my forte. So now that I've got it up,
okay,
let me see if I can summarize the question right back.
Okay.
Or maybe you can try to.
I think it's saying that is the effect you observe, and this is the very first figure, driven more by a drop in control group spending in wave 4 rather than an increase in treatment group spending.
Yeah, this is something that we also looked at, and it does look like that on this graph. So you may remember that one of the things that we did when a household qualified for a treatment group more than 4 waves, maybe they paid off their mortgage for 8 waves in the data. We randomly selected 4 consecutive waves to include in the data. It so happens that the first random draw looks like this, with this big control group drop. You can see that solid line, drops up just as the dotted line is trending down. The solid line drops in that 4th wave. We conducted 20 different random draws to see and ran the analysis each time to see if the different draws look different. And in fact, they did. We didn't always observe the graph looking like this deep control group drop. And in fact, the results didn't change appreciably. Like they were significant among each of the random draws that we did. But we happened to go with this first one, even though it looks suspicious and strange. So it's a great observation. As far as we can tell, that's not the driver of effect.
So I want to make sure, I think I just had the same problem with multitasking. You're sort of saying it might not be as big a drop as this particular graph shows, but what the basic story is the same.
So the thing is, this crazy drop doesn't happen every single time. We don't always see this pattern, this 4th wave pattern for the control group. When we randomly select the control group in a different way, it looks different, but our results remain intact.
I think I got that. Kind of stepping back broadly, was there anything, it's really a 2-part question. Is there anything that as you went through this, and I think you hinted at this, but I want to make sure we get it right, that really surprised you in your findings, that were, I think it's always interesting when we go in with a hypothesis and the data tells us a different story. So or maybe bigger than you thought. Anything that really stood out. I'll hold the second half of the question for a second. Go to that.
Sure. I mean, yeah, there were a couple things. I think the first point to make is that we expected that this result would be more larger, that the magnitude of result would be larger for households over 65, because as we age, we have compounded health needs. And we expected that we would see, if someone was 68 and finally paid off their mortgage, that householder may have been rationing more. Their income, their budget may have been a lot tighter because they had more health expenditures that were piling up. The effect of the probable effect of subsidy that starts at around 65 was huge. For the results to be pretty big and just go away entirely was not. We didn't anticipate seeing that. And then the other thing, honestly, we expected to find some difference. We expected that there would be some households that were low income that were rationing. We expected to find a couple dollars a month, maybe, difference. The size of the difference, a 50% increase, was very surprising. Maybe spoke more to method. There are other ways to approach this question, but it really suggests pretty clearly that there's rationing behavior going on, at least to some degree, for households that aren't yet receiving subsidy.
And I'm just trying to think about. I was very struck by that finding about. Geez, it turns out that universal health insurance, at least if you're over 65, has some important effects. Was there anything in the findings, I guess in your data, about the extent to which the over 65s had some form of supplemental insurance, particularly to cover prescription drug costs? Because I'm really wandering into a health policy field that I know dangerously little about.
So we did control for that. One of the demographic variables that we used was basically an insurance profile for the household. So the household would get a flag when they had a Part D, like drug supplemental insurance. So that did exist in the model, and we allowed that to be there. But I think bringing that up, I think it's a good point to bring up, because many of us who aren't yet on Medicare, I don't think recognize that Medicare doesn't pay for prescription drugs unless you purchase a supplemental plan. So that there are people who it's yet another reason not to expect that hitting 65 would have dramatically cushioned health spending, drugs, prescription drug out-of-pocket spending in particular. That's.
But I guess that was a little bit behind my question, which was, do you have a sense as to what share of the folks in your sample had actually the Part D insurance, supplemental insurance, excuse me, and did that make a difference? Did you see a noticeable increase in spending on pharmaceuticals among people who paid off their mortgage and then didn't get insurance, or maybe people paid off their mortgage and then used some of the proceeds to buy the insurance because they knew that they needed prescription drugs?
Yeah, that's a good question. Looking to see if I have it in front of me, the prescription drug coverage. I don't think I do. I don't remember exactly how many folks we had in the data that did have supplemental or Medicaid coverage. There are or who purchase. There are a couple different avenues, right, to get to that prescription drug coverage, including just having private insurance, right? A lot of 65-year-olds are still on employer insurance, but we tried to run the analysis looking at folks who had some kind of prescription drug coverage as compared to folks who didn't have prescription drug coverage. And for various reasons, we just couldn't separate that coverage from just being 65 because there are so many gaps in insurance coverage that close at that point that we couldn't separate the age effect from the effect of having coverage.
Yeah, and you said, I believe, I was kind of intrigued, given other timely differences, health-related differences in that are related to geography. But you said that your data doesn't allow you to start pulling out some of the geographic differences.
Not yet. Yeah, we just didn't have enough people, honestly, because we're looking at, we're splitting these groups so many different ways, and just to find the people in the data who had a mortgage and stopped paying it and met our criteria of being in for 2 waves with a mortgage and not being in for 2 mortgages and not moving and not getting divorced and not dying. And our sample ended up being small enough that we couldn't go get any geographic sense.
No, that's helpful. Two sort of wrap-up questions. The first, is there other work that? Well, it's really 3 questions. One is there other analyses that you're planning to do with this data? I think you already talked about some of that mortgage data, or that you would love to do with this data that's doable. And the second half of that question is there other kinds of data that you really need to untangle some of the questions we've been talking about?
Yeah, I mean, right. As you pointed out, I mentioned that we do want to expand our conversation about just what's happening in this end of mortgage period. It's not a period I think we understand very well. And as you kind of alluded to, we certainly went into this with this weird assumption that everyone who has a home mortgage just slowly pays it off and then it goes away, and that's how people behave. But it turns out that households are much more complex, and we would love to pick that apart a little bit more and better understand if there are certain trends, certain types of households that tend to use their mortgages differently, especially remembering the underlying motivation to this work is that older adult households are carrying mortgage debt longer. So if we, and as I said, maybe that's a good thing, right? Maybe instead of trying to die with the most assets, folks are actually using their assets to be healthier and have, a more satisfying older experience. Or maybe that's a reflection of people feeling very constrained and not having the options that they need to have in their latter years. So I think understanding who's doing what around this mortgage payoff period would at least help us begin to answer that question. And you asked about data to better understand, just take this analysis to the next level. I mean, I think, without kind of calling out specific data sets, I think what we would really love to do, what would be very helpful and interesting, is to think about the different ways that older adults receive subsidy. Subsidy could come through housing subsidy programs, right? Subsidy could come through income infusions, or Medicare, it could relieve the pressure to, on their healthcare. And all of those are going to have different implications. Some of them are going to be more efficient in some ways, Medicare going to everyone all at once without a lot of like application processes and administrative inefficiencies may work differently than a program like the supplemental program that folks have to actually apply to get access to a Medicare Part D program if it's not immediately affordable to them. But looking at those policies individually and thinking about which one has more impact, more bang for the buck, I think would be a great next step for this work.
It's funny because the question that I was just about to ask you is, given at least what you've done so far, and given just some of the broad national discourse on both housing and healthcare, do you have some thoughts about, are there some clear policy implications in your mind from what you found, and or does it point to some questions that we really need to know the more have a better answer, a sense of before we take a big policy step?
Yeah, I mean, thinking very, very currently, there is a national conversation right now about lowering the Medicare qualification age. And if we think about the impact that adults age 50 to 64 are feeling right now, where they might be having a harder time getting jobs, so they might have gotten dropped off of employer coverage. We see and hear that they were already, well before, this data ends in 2016. So they were already experiencing the implications of a constrained budget. So I think having that in mind would be very, having this larger policy conversation around the Medicare qualification age kind of informs and has a nice interplay with these findings, even though we weren't specifically studying the policy.
Sorry, I don't know if that loud beeping is coming from me.
It's me. It's me.
Okay.
Sorry.
Like, my fire alarm going off, or is that okay?
No, it's a truck outside.
Okay. No, I shut my camera for a second to shut the window, but is there anything else that we should have touched on that you want to make sure folks kind of take away from this, before we wrap up?
I mean, the only piece that I think would be kind of very helpful to walk away with is this clear understanding that the housing world and the health world don't necessarily operate hand in hand, but are very intimately connected, right? I mean, when we're talking about the end of mortgage period, we might be talking about finance, and we might be talking about, just all kinds of like asset allocation decisions. But it turns out that might have like intimate experiences about somebody's ability to take a prescription their doctor gave them down to, their local drugstore and get a medicine. And I think thinking about the interplay on the ground is critical.
And when you said that, I found myself, I was remembering when we were interviewing you as for one of the postdocs, and that was, truthfully the great appeal, which was, we're the Joint Center for Housing Studies. We know housing, or we think we know housing. And, you were bringing in a sort of a healthcare lens, which was something that, we've always known, but the ability to sort of, the familiarity with this data set, the ability to think about it, and the ability to start thinking about how does this connect. And then as you were speaking, I was also thinking about the last speaker in the series, Carlos Martin, telling almost exactly the same story about the fact that the environmental community, particularly people thinking about decarbonization, haven't, and some of the folks thinking about disaster preparedness haven't been thinking about housing. And of course, we all think that, as Matt Desmond says, the rent eats first. But when we asked you to offered you the postdoctoral fellowship, I think it was because we were really excited by the prospect of you helping us lead us through the kind of work that you presented today, which, as we've already noted, has some really, I think, surprising findings, and suggests some really important policy implications. And, that to me is the goal of the work that we do. So I just want to thank you on behalf of the center and all the folks that you can't see who are tuned into this webinar, for a really interesting, thoughtful, and very, very clear presentation. This is a kind of stuff that you could have really easily gotten lost in the weeds. So you can't hear it or see it, but everybody is joining me in thanking you for just a terrific talk. Thank you.
Thanks for a wonderful conversation.
All right.